All right, again, welcome everybody. My name is Jeremy Husted. I'm a physician at WVU Medicine. I was asked to do this. Actually, I think I volunteered to do this one a while ago, but talk a little bit about Kratom, which I'm sure everybody has experienced in one way or another in the community at this point. So I'm going to talk a bit about it today. And again, questions are welcome. Before we get started, just wanted to wish all the moms out there happy Mother's Day belated. So if you've forgotten to call your mom, this is your last chance. If we got one day post post Sunday. Anyways, the title of this talk is Kratom and 7-OH, Pharmacology, Abuse Potential, and Legal Status. That's me. That's today. Let's see if we get this working. There we go. Disclosures. I don't have any disclosures. I don't work for any pharmaceutical companies. I don't own any stock in Big Kratom or whatever it might be. So nothing along those lines. I work mainly in outpatient. My main focus right now is the IOP program here. I'm triple boarded in general psychiatry, addiction medicine, and addiction psychiatry. Additionally, serve the West Virginia Society of Addiction Medicine. So if we have any WVCTSIs on there, welcome. Also, alternate Region 5 director now, for what it's worth. We're going to talk a little about the origins and traditional use of Kratom. So it's actually been around for a long time and is not necessarily something you just see in smoke shops these days. Look a little bit about the biochemistry of mitragynine, that's how I say it at least, and 7-OH, 7-hydroxymitragynine. Talk a bit about the abuse potential of them and toxicity, and go into a little bit the current legal status of West Virginia, which it's actually changed not too long ago. So my goals, as always, try to minimize filler words, no cursing while recording, since this does go on YouTube. So I'll try not to say anything. If we pause for question and answers, I might throw in a couple colorful words. We'll see. All right, so Metragina speciosa, that's the way that I looked up how to pronounce it, but this is the plant itself, kratom plant. So there's botanical characteristics. It's a tropical, evergreen tree with large, glossy, oval leaves adapted to humid, swampy environments. That's kind of what it looks like. It has psychoactive alkaloids. It's actually a complex mixture of over 40 indole alkaloids responsible for its psychoactive properties. So in a way, it's a little bit like cannabis, where there's lots of chemicals within it and they do various things, but there's some that we think of, worry about more than others. It has environmental adaptations, so it thrives in moist riverbanks and flood-prone soils, showing natural resilience to prolonged moisture. So it can basically survive in swampy kind of settings. And it has variability of usage, so there's variations in the genetics and processing, which cause inconsistent potency. So this impacts traditional and modern kratom uses. So basically how it's grown and how it's processed changes the way it works. So a little bit of where it's found and the traditional use of it. It's actually native, it's indigenous to Southeast Asia, so areas like Thailand, Malaysia, Indonesia, Myanmar, and Cambodia, where you find it. Traditional labor use, so the way it was used in the past is that you have rural workers would chew kratom leaves, so they kind of have it and they'd chew it, or they'd brew teas to relieve fatigue and increase endurance during long physical work hours. It's actually kind of used similar to the way that nicotine largely was in the past, or in a way caffeine too, if you ate some like coffee seeds, but similar in a way to tobacco. So some medicinal and social practices used in folk medicine for treating things like diarrhea, fever, pain, and wounds through communally, socially regulated practices, so historically. Now what we have, of course, is modern commercialization. So this has really shifted the use of kratom. It also increases the amount of course of exposure and risk compared to traditional low dose whole leaf use. So historically, people would use small amounts, again, like chew on a leaf, roll it up. Now what we have, as with anything, is commercialization, mass production, mass distribution. So a little bit in terms of the chemistry of it. It's an alkaloid. So mitragynine, that's again how I say it. You can look up online. I've been on various things like Reddit, and and how people prefer pronouncing it, but you'll see like mitragynine, or I say mitragynine, that gives out my Pittsburgh roots a little bit, mitragynine. But mitragynine is the most abundant kratom alkaloid present. This makes up 1 to 2% of dried leaf weight with variable concentration. So mitragynine is largely what we're talking about, the active ingredient. So the other one, which you've heard and we'll talk about, is 7-OH or 7-hydroxymitragynine. So this is also present. So it's much less present in the normal plant, but it has a higher affinity and efficacy at the mu-opioid receptors. So 7-OH, 7-hydroxymitragynine, works very much like a traditional opioid in terms of when you ingest it, your brain basically sees it as an opioid. I think my cat might be visiting. So, we want some kratom. Alkaloid profile complexity. So kratom's alkaloid profile varies due to how you dry it, how you extract chemicals from it. This, of course, affects how the opioid receptor perceives it, and regulatory challenges as well. So in terms of what's permissible by law, what's basically ignored by law, and what's changing now law. So some toxicological considerations. So really, if we talk about the risks of kratom, it's important to know like how much alkaloid's present, so the content, especially how much of it is the 7-OH in particular, beyond just mitragynine. So we kind of know that mitragynine is going to be present in kratom. It's how much 7-hydroxymitragynine, 7-OH is present. So a bit in the pharmacology. Mitragynine itself is actually a partial agonist at mu-opioid receptors. So it partially activates the receptors, which is not too dissimilar to buprenorphine, actually. So this produces a lower maximal effect than a full opioid agonist like morphine. So in some ways, kratom, at least mitragynine component, is a partial agonist like buprenorphine. Interesting. It also has adrenergic and serotonergic effects. So it works with the alpha-2 adrenergic receptors, so basically affecting like parasympathetic, sympathetic pathways. And this influences stimulant, analgesic, and mood effects. So it's almost, I've heard it described as like a child of both opioids and of stimulants, the effects of it. So you have dose-dependent effects typically with kratom. So lower doses increase alertness and social ability. So this is more or less the stimulant effects of kratom, and then higher doses cause sedation, analgesia, and euphoria. So this is more your opioid effects. Safety and dependency considerations. So despite the lower efficacy of it being a partial agonist, mitragynine itself, without the 7-OH part, can cause dependence, tolerance, and withdrawal. So if you use a lot of it, you can certainly go through withdrawal, which clinically we've seen a lot recently, especially with 7-OH, but we've seen, and I'm sure you all have encountered as well. So what about 7-hydroxymitragynine or 7-OH? So it's considered largely, it is present in the plant itself, but it's also a metabolite. So what does that mean? So it's very potent. It's 5 to 22 times more potent than mitragynine alone at the mu-opioid receptor. So this produces more stronger analgesic and sedative effects of it. Endogenous formation. So while normal kratom has little presence, so if you get the kratom plant, there's not a whole lot of 7-OH there. It does form in the body of people through hepatic metabolism. So the idea is if you take mitragynine, if you ingest mitragynine, your body turns some of it into 7-OH, 7-hydroxymitragynine. So this in part explains why mitragynine does work on opioid receptors. So on top of that, you have synthetic now or enriched 7-OH, and this bypasses human metabolism. So instead of your body making it, someone is either deriving it from the plant or basically changing mitragynine to act like to become 7-hydroxymitragynine. So this raises the toxicological problems and, of course, creates these regulatory challenges that we're seeing. So a little bit more into metabolism. So it's an enzymatic conversion process. So your body changes mitragynine into 7-OH, mainly through the cytochrome port P450. It's especially the CYP3A4, which for those of us who love pharmacology, this is the same enzyme that breaks down things like buprenorphine. It breaks down partially methadone, also breaks down fentanyl. So It's kind of interesting. It's the same enzyme for all three. Some things that affect this. So the conversion of metragine to 7-OH, this can vary depending on the dose, how it's administered, someone's metabolism, and also you have drug-drug interactions. So we've talked about a little bit before, but there are drugs out there that either inhibit CYP3A4, things like Prozac, for example. So that would mean that it would take longer for 7-OH to be turned into or made into. But then you also have things like inducers. So often that can be like seizure medicines that mean the enzyme is actually more active, interestingly. So a little bit more regulatory importance. Understanding this pathway really helps aid clinicians in overdose risk assessment and regulators in controlling potent kratom products. So in theory, if you say have a patient that's on a lot of inducers, the things again like medications for seizures, they might have higher levels of 7-OH if they consume just plain metragenine kratom. All right. So some acute and chronic effects. So acute effects, so analgesia, which isn't so bad, so that's pain control. Sedation depends. Euphoria, everybody likes to feel a little high. Stimulant-like effects at low doses. Some common side effects you have are things like nausea and tachycardia, so high heart rate. Some toxicities at higher doses. So the higher you go, again, the more it acts like an opioid. So this is things like respiratory depression, altered mental status, and potentially even overdose, especially with 7-OH. So there's definitely more cases of overdose with 7-OH as opposed to plain metragenine. But again, the body turns metragenine into 7-OH, so it's a little tricky. Chronic use and withdrawal. It does lead to tolerance and withdrawal symptoms like anxiety, insomnia, and muscle aches, very similar to traditional opioids of abuse. So the withdrawal looks very much like someone coming off of opioids. So severe adverse outcomes, so things like seizures can happen, hepatotoxicity, so liver damage, cardiac arrhythmias, and this is often worsened by polysubstance use. And of course, a lot of what we treat is polysubstance use these days. A little bit more into abuse potential and epidemiology. So this is mildly controversial in terms of how do you diagnose kratom use. So right now, the parlance is saying it's kratom use disorder and not opioid use disorder. So at least from a SAMHSA side, they have not gone so far as to say that we should call this opioid use disorder. But it's one of those things that it looks like a duck, it quacks like a duck, it moves like a duck. It's a duck. It's opioid use disorder. But as of right now, we're saying it's more kratom use disorder. So about 1/4 of people who frequently use kratom do meet criteria for at least a mild use disorder. So even if we're not calling it an opioid use disorder, all the other things that we would see, all the symptoms that we would think to diagnose a use disorder are present. So things like tolerance, withdrawal, cravings, etc. We've certainly seen an increase in exposure cases. So kratom-related exposure in the U.S. increased at least tenfold in the last 10 years, according to poison control data. It's a bit hard to capture overdoses related to kratom alone because it's not widely tested for kratom. That's slowly changing, but you don't see a whole lot of testing being done for kratom. Severe outcomes and hospitalizations and fatalities have occurred, especially again with concentrated extracts or synthetic products, i.e. 7-OH. So more regulatory impacts. States with clear regulation on kratom products in general report fewer severe kratom-related outcomes. So surprise, surprise, states that have regulated it more tightly have less adverse outcomes than those that have minimal oversight. All right, on to where do things stand right now legally in West Virginia. So this is actually very new, but the act is relating to registration and enforcement of kratom products. So that's a snappy bill title, but it's the West Virginia Senate Bill 985. And this was signed into law by the governor on April 1st. It had a 90-day window, so it's supposed to take effect on June 12th. So this requires age verification for all kratom purchases, accurate product labeling, including how much alkaloid is the alkaloid content that's present. So this includes the metragenine and 7-hydroxymetrabinase, metragenine. Also prohibits the sale of adulterated or synthetic kratom products. So this can be a little bit difficult to say, what is synthetic or adulterated. So if you're, again, trying to design a product that has really high levels of 7-OH, how do we test for it? All right. Also, products cannot be marketed to minors. This is always fuzzy because a lot of times products you see are things like gummy bears, which I would argue that anytime you make anything into a gummy bear form, you are marketing to a minor. But anyways, so this is considered a regulated consumer protection model. So we are regulating it now as a plant-based consumer product under the West Virginia Department of Agriculture instead of prohibiting it outright. I would personally be more in favor of outright prohibition, but anyways, as of right now, it's legal for adults 21 and older. So retailers must obtain permits and enforce age verification. In theory, a third violation offense can actually lead to revocation of the sales license. So if you are a smoke shop as of June 12th and you get caught selling underage, first time I think it's $2,500 fine. Second time I believe it's $5,000, and then third time it's like $10,000, and you can't sell it there anymore. So we'll see what happens now that the law is going to go into effect very soon. All right, another one. I don't know if anyone's actually heard of this, and this is kind of a new one that's emerging. But we have the metragenine, or usually people just call it kratom. We have 7-O's, 7-OHs. Now we have this one called metragenine pseudoindoxil. So this is the new one to kind of put on your radar. So it'll be people will call it pseudo or MP, and this is a highly potent semi-synthetic mu-opioid receptor agonist. So this is actually a rearranged metabolite formed from metragenine via oxidative metabolism. So you're taking metragenine, chemically altering it, and turning into something just as potent, if not more potent, than 7-OH. So in theory, there's therapeutic uses to this. So a thought is that potentially it has less respiratory depression. So this is kind of preclinical data that maybe, if we're using it as an alternative to an opioid, it's less likely to cause respiratory depression. So there's interest in this being a next generation pain medication. It may actually continue to be effective in people who are otherwise opioid tolerant. So that's at least in animals. But again, it is high potency, so there is a risk of respiratory depression and overdose if you go high enough. So anytime any opioid or opioid agonist is unregulated, you're running the risk of overdose. So there is a potential for dependence and abuse similar to other opioids. So emerging synthetic analogs like this may increase toxicity risk in theory, because again, this stuff really hasn't been tested very well. It has kind of a double-edged connotation to it. So you have this idea that it could be an opioid alternative, although I would say, it does the exact same things more or less as an opioid. So I don't know how alternative it really is, versus it being a high-potency risk driver in novel kratom products. So people wanting to sell this stuff. And of course, this is very difficult to test for. So in theory, this should be illegal in West Virginia with the new bill, given its semi-synthetic nature, because this is not something that you are going to find in a normal kratom plant. This is something that is chemically altered, akin to basically the deltas that we have, the delta THCs, so delta 8, delta 10, it's kind of similar in a way. All right, some clinical pearls. We're almost done here. So for those using kratom, specifically 7-OH, they tend to have moderate to severe opioid withdrawals, and we have actually had to place them on maintenance MOUD often. So a lot of these people that we have coming in, we've had to put them on things like buprenorphine. Sometimes we've tried opioid detoxes and putting them on naltrexone, but a lot of people are ending up on MOUD because their cravings, their withdrawals are so high. I actually just saw a patient a few days ago who, out of the blue, he doesn't really have a history of serious opioid use, and he told me that he had bought something legal from the dispensary, and now he couldn't stop it, and he had to use it every few hours just not to get sick. And of course, it was 7-O's, and now that person's on buprenorphine. We'll see how they do. So cases of overdose in general from kratom are rare, but are a concern, especially when you're mixing it with other sedatives, even other opioids. So you don't see a ton of overdoses, and they're kind of difficult to track in a way right now, but it is a concern with kratom, especially 7-OH. A lot of proponents of kratom consider it as a substitute for MOUD. So this is often how you see it marketed: is you don't have to see a doctor, you don't have to be on an evil buprenorphine. You can take kratom instead. So that's often how I've seen it before, or as a comparatively safer intoxicant. So people like getting high. This is something you can get high on, and it's less likely to hurt you. Of course, it's not approved for opioid use. So even though some people use it to help them come off of opioids or stay off opioids, there's no FDA data that's never been approved for that usage. Of course, it is difficult, as I've mentioned a couple times, to test for kratom. Right now, here we generally only can for mitragynine. So when we send out orders, as of right now, I've only found we can actually test specifically for mitragynine, not 7-OH by itself. So it's really difficult clinically to know who of our patients are even using it. I would definitely favor tighter controls or an outright ban on kratom products, just knowing what I've seen in patients who have struggled with it. And certainly at the very least, we need to be warning people about this. We need there to be more understanding of the risks involved to be using this. In conclusion, so kratom and 7-OH, it's a plant used for centuries for its various properties. Low doses, it acts more as a stimulant. Higher doses, it does act more as an opioid. Overdoses are rare but possible given how it works on mu-opioid receptors. 7-OH is a more potent version that is found in low doses in plant, made semi-synthetically from mitragynine, and is a metabolite in the human body from mitragynine, so you will see it. There is abuse potential, and it is difficult to test for kratom. There's some consumer protections in the state, but it remains widely available. And I'm curious to see, with the laws changing, again, are you going to see 50 smoke shops or whatever we have in Morgantown? And I'm sure that there's definitely more smoke shops in the state than there is treatment for addiction. So be wary of use while treating your SUD patients, because they are using it. It is widely available, and it's something that should concern us. So does anyone have any questions? Hopefully this is a decent overview of everything, and of course we'll make the slides available to everybody. So I'm going to stop sharing here so I can see the screens a little better.